It's important to understand that BPH, or benign prostate hyperplasia, benign enlargement of the prostate, is not generally associated at all with prostate cancer. And I tell men that these are both diseases or disease processes that can take place in the same organ, but they have nothing to do with each other. BPH generally presents with a set of symptoms, and there are two categories of those symptoms. There are obstructive symptoms, which include weak stream, trouble starting the stream, starting and stopping, incomplete emptying, and it can also include irritative symptoms, frequent urination, urgent urination. Sometimes when you get that signal to go, you've got to go right away and you may not make it to a bathroom, and also waking up at night to go to the bathroom. Now, those symptoms, until proven otherwise, are generally assumed to be due to benign enlargement of the prostate. Having those symptoms should not in any way make a patient feel that they have prostate cancer. And conversely, if you have no symptoms, that does not mean that you're less likely to have prostate cancer. Prostate cancer is generally diagnosed without any symptoms, and it's diagnosed with a routine blood test called a PSA. I try to explain to patients, I try to put it in terms that they can really understand. And I talk in terms of the pump and a pipe. To talk in terms of the bladder being the pump, so that's what generates the force of the urine. And then the pipe is the tube that goes through the prostate. And that's what the prostate can constrict that pipe. If you have a bigger prostate that's blocking, you may need to do a more extensive intervention to open up that channel. If you have a smaller prostate, then oftentimes an office procedure may be sufficient. But it's also important to really think about the bladder as a muscle, as a smooth muscle. And this is sort of definitely becoming more widespread, and it traditionally wasn't. That the bladder, like the heart, is a smooth muscle which generates force, and patients can't know how much force it's generating. And as physicians, we can't know by looking inside, but that has to be studied. And I take the force that the bladder generates, the size of the prostate, and how the prostate looks visually. And usually with those three pieces of information, we can come to a certain set of options that exist, whether it's office-based or outpatient, that's best for that patient. So if the bladder generates a really high pressure, I'm more willing to do something office-based because you may just need a little opening of the channel to give them a good flow. Conversely, if the bladder has deteriorated over time by pushing too hard and it's not generating a high force, then I tell the patients, I need to manage your expectations that if I just open it a little bit, it may just not be enough force to get through that channel. We may need to do something that creates a wider channel. So I really think it's important to get a lot of information so that you can counsel the patient appropriately. I'm able to offer patients almost the full spectrum of minimally invasive options. So, and for several of those, I've been designated as a center of excellence. That's both for Urolift as well as a green light laser procedure. So I tell the patients that these are the options, and sometimes it can seem overwhelming to have a lot of options, but I will offer all of them so that I don't want to feel that as a provider, I'm sort of steering them to something that I do as opposed to something that I don't do. And for the patients to feel comfortable that if they feel that they want A versus B versus C, that I'm able to sort of provide them a high quality procedure. So I categorize it as office-based options, which would be mostly the Resumè, which is the steam-based option, or Urolift, which is just pinning open the prostate. Those are ideal for patients who either are not good surgical candidates or people who just don't want to go to the hospital. For patients who have smaller prostates, especially when the bladder is really generating a robust force. And also for patients who, I tell them, if it works, great, but if it doesn't work, it wouldn't be devastating. If a patient says, I want a procedure that has the lowest retreatment rate and something that's going to be very unlikely for me to need to be doing a repeat procedure, then I tell them an office procedure may not be appropriate for you. But if you'd be willing to do this, knowing that there aren't any bridges that are being burned, so if it doesn't work, we could do something else, then I think those procedures are what I would offer them. If someone wants something in the hospital, that's traditionally the green light photovaporization or the aquablation. And it really depends on the size of the prostate, the patient's desired side effects, what's tolerable to them, what's not tolerable to them, whether they're willing to stay in the hospital an extra night, whether they're on blood thinners. And really, it's not a one size fits all, but it's understanding what the patient's preferences are and what their preferred outcomes are. And then together, we jointly usually land on a procedure that's going to best suit their needs. The Resumè procedure is an office-based procedure that is steam-based. So that includes the patient being just with a minor sedation. So we use something called Pronox. So the patient can drive themselves to the office, they can drive themselves home. There's no IV, it's not in the hospital, and they are sitting on the exam table. We take a telescope or camera, go in through the urethra, which is a tube that connects the bladder to the outside. And when we go in, we're visually inspecting the prostate, and where the prostate's enlarged through this special scope, a needle comes out and then high pressured steam goes into the prostate. Now, that steam basically heats and then destroys the prostate cells, but that's not something that happens overnight. The patients have a catheter that they'll go home with, and that's usually in place for 3 to 5 days. And after the catheter comes out, for another several weeks, the cells that got the heat die. And as they die, the channel on the inside of the prostate opens up. So sometimes patients come in, usually about 6 weeks later, and they're feeling much better. But I do tell them for those first several weeks, they may have some irritative symptoms until all the healing is done. A Urolift is an option that for enlarged prostate for appropriate men who have smaller prostates. So that would be anything that's not too large. It's for men who want something in the office, who don't want to go to the operating room, or it's too high risk to go to the operating room. And this is a procedure that does not require any heat, does not require any cutting, it does not require any removal of tissue. Rather, it's mechanically unblocking by almost either stapling open, or people use the analogy of sort of holding open the curtains or pinning the curtains open. So it's taking the tissue and unobstructing the urethra, which is a tube that travels through the prostate so that the urine can go from the bladder out in an unobstructed or unimpeded way. Green light is a procedure, we call it green light, but it's also called photovaporization of the prostate. It's an outpatient procedure that's done in the hospital setting under general anesthesia. It uses a special laser that actually vaporizes the tissue. So the advantage of the green light as opposed to the traditional Roto-Rooter is that there's almost no bleeding. The visualization is great, and you use the laser to vaporize tissue to destroy it, to open up the channel. It can be done for patients who are not able to come off blood thinners. It takes anywhere from 30 to 45 minutes in the operating room. Patients generally have a catheter for a day. They go home the same day and the catheter comes out the next day. Often, if there's no bleeding and the patient was urinating fine before the procedure, they may not even need a catheter. Aquablation is sort of the newest tool in our kit. The aquablation is, the analogy would be pressure washing the inside of the prostate. So what's amazing about aquablation and how it sort of revolutionized the treatment of enlarged prostate is that it's an option which can treat small prostates, it can treat large prostates, and it has some of the lowest side effect profiles. So traditionally, for larger prostates, we needed to do more extensive intervention, which either meant that the patients had a longer recovery or more side effects, whether that's sexual side effects or urinary side effects. So to be able to offer an option for a patient that can be done in either same day or one night stay in the hospital and can treat very large prostates, which previously were not able to be treated in a minimally invasive way without having sexual side effects or urinary side effects is really an amazing sort of revolution. The way it works is it also allows us to individualize the plan, the surgical treatment plan, to the patient. And the reason we can do that is that there are two simultaneous ways of visualizing the prostate. The patient's asleep during the procedure. We have an ultrasound probe that sits in the rectum, and it's giving us real-time ultrasound images of the prostate throughout the procedure. And the other is the traditional camera that we look at on the inside. We use the ultrasound to map on a computer. That's part of the robotic system of the Aquablation. So we map the patient's individual anatomy. We make sure that we can know what tissue we want to remove, and we also can know exactly what tissue we want to save. So we know if it's near the sphincter that we don't want to be anywhere near there. If it's near the area of the prostate that has to do with ejaculation, we want to avoid that. If it's near anywhere where there are blood vessels, we avoid that. But we're also able to take a tremendous amount of tissue in a athermal way. That means no heat. So the water is not heated, and it's able to create a very wide channel and do it in a way that leads to excellent, durable results without sexual side effects, without urinary incontinence, and in a way that patients who have very large prostates tell me that they feel like they're a 20-year-old again when they come in 2, 3, 4 weeks later. So I think it's really been the biggest game changer for us in minimally invasive options for enlarged prostate for those reasons.